Hi, I'm Dr. Abhishek Mangeshikar, an endometriosis specialist and excision surgeon. Today we're going to discuss an important but often overlooked topic, uterine malformations and endometriosis, and how these two conditions can be linked. Many women with endometriosis also have congenital uterine anomalies, meaning they were born with a uterus that is shaped differently than the typical anatomy. These uterine malformations can contribute to pelvic pain, menstrual problems, infertility, and possibility to the development or worsening of endometriosis. In this video, I'll cover what uterine malformations are, how they're classified, how they may be linked to endometriosis, symptoms to watch out for, how we diagnose and manage both conditions together, and why seeing an experienced specialist is key if this is suspected. Let's begin. Uterine malformations, also called Mullerian anomalies, occur when the uterus does not develop normally in the womb. They are congenital, meaning present from birth, though many women are unaware of them until later in life. These anomalies happen when the Mullerian ducts, which form the uterus, fallopian tube, cervix, and upper vagina, fail to develop properly or fail to fuse correctly. Here are some of the most common types. A septate uterus is a fibrous or muscular septum that divides the uterine cavity. This is the most common uterine anomaly. It's linked to infertility and miscarriage. A biconjugate uterus is a uterus having two horns, giving it a heart shape. This can cause menstrual problems and pregnancy complications. A uniconjugate uterus is only when one side of the uterus develops. It may have a rudimentary horn, sometimes with no connection to the main uterus. There's a higher risk of endometriosis if menstrual blood is trapped. A didelphys uterus is two separate uterine cavities and two cervices. This may also involve a vaginal septum resulting in two vaginal openings. Obstructive anomalies, for example, a non-communicating horn or imperforate hymen which can block menstrual flow. How are uterine malformations linked to endometriosis? These are especially linked to endometriosis due to retrograde menstruation, although that is not a highly evidence-based theory. Here's where it gets important for endometriosis patients. Several mechanisms may link these two conditions. Retrograde menstruation. In obstructive anomalies, menstrual blood cannot exit properly, leading to backflow into the pelvis. This can deposit endometrial cells into the peritoneal cavity, contributing to endometriosis development. When it comes to retrograde menstruation regarding the pathogenesis of endometriosis, there are much more widely accepted theories available today. Altered uterine contractility. In anomalies like biconjugate or septate uterus, abnormal uterine shape can impair normal contractions during menstruation. This may promote retrograde flow and increase endometriosis risk. Coexisting developmental anomalies. Some congenital factors may predispose a woman to both uterine anomalies and endometriosis. Speaking of the theories of mulleriosis and mullerianosis, this is a more plausible theory. Because of uterine malformations and defects in the separation of the organ systems during embryogenesis, these type of cells that later undergo transformation into endometriosis are laid down along similar track. So hence, extrapolating that logic, it is very easy to understand why someone with defect in this system may also be more prone to developing endometriosis. Women with both uterine anomalies and endometriosis may present with severe dysmenorrhea or painful periods, chronic pelvic pain not limited to the periods, irregular or heavy bleeding, recurrent miscarriage or infertility, pain with intercourse, bowel or bladder symptoms if adhesions are present within those organs. In some cases, especially with obstructive anomalies, young women may present shortly after menarche with severe pain and no menstrual flow. Accurate diagnosis requires specialist imaging and a high degree of suspicion. Here's what we typically do. A pelvic MRI is best for visualizing uterine anatomy. It can also detect deep infiltrating endometriosis. 3D transvaginal ultrasound is excellent for mapping uterine shape and detecting septums or biconjugate uterus. Diagnostic laparoscopy and hysteroscopy. If surgery is indicated, this allows direct visualization of both endometriosis lesions and uterine anomalies. A hysteroscopy can treat certain anomalies, example, a septum resection. How we manage these conditions together. Number 1. Address the uterine malformation. A septum can be removed via hysteroscopic resection. Obstructive anomalies require surgical correction to restore flow. Number 2. Treat the endometriosis. Excision surgery to remove endometriosis lesions and pelvic adhesions. Nerve sparing and fertility sparing techniques are critical in these cases. Number 3. Optimize fertility. Once the uterine anatomy and pelvic environment are optimized, many women have improved natural conception rates, experience reduced miscarriage risk, and have better outcomes with IVF if needed. These cases are complex and require a multidisciplinary approach. Expertise in excision surgery, skilled reproductive imaging, collaboration with fertility specialists, understanding of both pelvic disease and uterine anatomy. In my practice, I work closely with radiologists trained in reproductive imaging, fertility experts, reconstructive gynecological surgeons. Our goal is to provide comprehensive fertility-sparing care, tailored to each woman's anatomy and disease state. There is a path forward. If you have known uterine anomalies and/or severe pelvic pain, infertility, or recurrent miscarriage, please know that there is a strong possibility that both conditions are contributing. With the right team, we can identify and treat uterine anomalies, excise the endometriosis thoroughly, optimize your chances for natural conception or assisted pregnancy, dramatically improve quality of life. Early diagnosis and specialist care are key. Thank you for watching this video. I hope this helped explain the important connection between uterine malformations and endometriosis and how we approach treatment. If you have personal experience with this, or if you'd like to ask questions about specialist care, surgery, or fertility planning, please leave a comment. And if this video was helpful, please like, share, and subscribe for more expert content on endometriosis, excision surgery, fertility, and advanced pelvic health. Take care, and I'll see you in the next video.